the two labs that we use on our board are the ones who came up with this design. We think you're going to use the 4, 5, and 6 millimeters. But if, let's say, you want a 6.5 millimeter, or you want to customize it, it's easy to do. You can do it in the mouth. It's probably easier outside the mouth. You can reduce this titanium, put a different margin on. It's however you want to do it, because the screw is way down low, so you have plenty of height of metal to customize your own crown. We will be making a customizable crown, like a UCLA abutment sort of, for the labs. The labs were asking, you know, can we have, because like I said, in our country, almost every abutment now is a customized abutment, and you can do that, and we will make that as well, so that you will just take a transfer impression, and then the lab can go ahead and wax whatever crown you want or they want, as well as the option of a screw retained crown. I don't think that's necessary, but we've had a few people suggest it, especially the prosthodontists, because now they're going back to screw retained because of the cement retention causing a problem with the tissue. However, on our abutment, the margin is up here, and then it's not real subgingival. So I don't think that's a problem. However, just for those people who want to do a screw retain, we'll make that for you as well. This is our restorative kit. It's very simple. This is a really nice adjustable torque wrench. If you don't do placement of implants and you don't buy the surgical kit and you don't get this this adjustable torque wrench, it comes right now in the restorative tray. But as we said, we're only recommending that you torque that capture screw, that spiral lock capture screw, to 25 Newton centimeters. And this goes up to, I think, 60. So if by chance you had it sitting there and you weren't paying attention and you're like Brad, you put it in at 50 Newton centimeters and you just grabbed it and you just torqued our capture screw down. Our capture screw is designed to withstand that much force, but we don't recommend it. So we're probably going to replace this with just a simple 25 Newton centimeter torque wrench, and that'll make it very easy. These are the try-in. These are just for the heights, so you can see which one that you want to open, because they're sterile, so you don't want to just open them and try them in. This will tell you, oh, I need a number 6 here, and then you'll just open it up and put it in. This is a carrier so that you can just grab these on the side, take them into the mouth, set them down, have a look, have them decide what size you want. Makes it a little bit more easier where you don't have to put your fingers in there and hold it, because there's 2 little anti-rotational pegs that secure it pretty well. Once you put it in there, you could leave it and it'll stay in there pretty well, just to have a look. And then these are just hex drivers here as well. Also, with that little side notch in there, that little concave area, it's also an area where when you cement the crown, it gives it a little bit of a well for the cement to go into. Now, as you know, you use just very little cement. With the 6-degree angle of an abutment, you need almost no cement to hold that on, and yet that gives us a little space for the cement to fill in as well. If you were using a CEREC unit or scanning any kind of digital impressioning, you just block those out. So the nice thing, I think, is when you take off the tissue former, you're going to have a well, because this tissue former is not platform switched. It goes right to the end of the edge. You'll have a nice well of tissue that's basically pushed back, almost retracted, so that when you put the abutment in, you've chosen the abutment, you're going to put it in, you're going to torque the abutment to 25 Newton centimeters, and you're going to end up with this. You're still going to have it retracted around there for a while. So if you were scanning, I think you're going to be able to scan the margin down there, and especially when the new abutment's going to have a big heavy chamfer, you'll be able to scan it without retracting. If you want to retract it a little more, it'll be easy to do, or if you want to use a laser and clear the margin, make the margin more visible, you can do that. But what we've done here, and then you go to the crown, and if you're a CEREC user, you would scan it, and in an hour or so, you have a beautiful crown. But what we've eliminated is the need for these abutment analogs, the transfer analogs, as well as the implant analog. I was explaining to someone here at the break that for me to do this, these are both around $55, so I have $110 in there, and an extra step that I've totally eliminated. So on our system, you're actually going to save quite a bit of money, as well as eliminate another lab procedure. So our planned studies, we're going to be getting here as soon as the first of the year. We're going to do University of Colorado. Dr. Lonnie Johnson will be doing that along with Brad and myself. We've got patients that are anxious to get going with this. We have an independent research organization that's going to be doing more research for us. We have what's called a bioscience innovation group here in this country, where we have some of the top implantologists and surgeons who are placing, studying, following, giving us the data. And that's where Dr. Ranahan was talking about. It's interesting because we had a surgeon who split a ridge on the maxilla to put this in. Very interesting, worked well. Everyone has grafted this post-insertion. We have them where they're talking about immediately placing these. I'm not a big immediate load believer. I think on these cases you need to be patient. Why not do it right the first time, and the patient's happy, you're happy, you don't have to go back and redo anything. And yet we know there's dentists out there that are going to push the envelope. We just know they are. We aren't going to be there for every surgery, and I just hope they'll be honest with us if there's a problem, or tell us what the results were. One of our innovation group surgeons, we left him the couple of kits and some implants, and he just told us he's going to do them immediate. He's going to graft it and do some immediate placement. You know, we think if you get primary stability, it could be okay, but you know, that's not really what we're recommending.
We don't recommend it, but understand we don't limit you. You use your own
ability and your own skill level, whatever you're used to doing.